Good afternoon, Dr. Bishop.
Good afternoon.
To start off, could you tell me where you went to medical school?
I went to Tufts Medical School in Boston
And when did you graduate?
in 1966.
When did you start practicing?
In 1974 here in Worcester.
And what was your specialty?
It was cardiology.
What made you choose cardiology?
It happened, I guess, I started as in internal medicine training, and I did electives in cardiology. I was in Baltimore at the time. I had some opportunities to do cardiology electives at Johns Hopkins, and there was a position open in the cardiology fellowship at Johns Hopkins, which was offered to me. It was an exciting possibility, so I took it.
Could you describe a typical day when you first started practicing?
Well, I started in 1974, and I would say that much more of it was spent in the hospital than we spend nowadays. It would not. I would start. I'm an early morning riser, so I would start generally early in the hospital, 6:30 or 7 o'clock, and it would not be uncommon to have 15 or 20 patients in the hospital, and it would not be uncommon to go to 3 or 4 different hospitals. So the bulk of the morning was in hospitals, seeing patients that you'd admitted or seeing consults in the hospital. And then the afternoon was usually spent in the office. Considerably different than now, where people are 10 minutes in the hospital and then the bulk of the day in the office.
Did your day change at all over years of practice, or did it remain the same?
It did. More and more patients began to be treated as outpatients. Hospitalization was less and less. I think for a variety of reasons, people were hospitalized much more frequently. In 1974, it was much harder to obtain outpatient testing. People stayed in the hospital considerably longer lengths of time. Back in those days, people were occasionally even hospitalized for routine physical exams because it was simply easier to get all the tests together in a day or two, which would have taken weeks in an outpatient setting. So it's really shifted from sort of, I think most physicians' practices have shifted largely from, or much more from a hospital-based system to an outpatient system.
So what were your hours like?
But I would, they would be variable, but I would start at 7 in the morning usually, and on a good day I'd probably finish at 6 o'clock, probably finish seeing patients at 5:30, return phone calls and so forth. On a bad day, it would be 8 or 9 o'clock at night, and then of course with frequent phone calls in the night and weekends and so forth.
Did you ever make house calls?
I never did. I never made house calls. I did go to a lot of different hospitals. That was quite different. It was not uncommon to travel. It was not uncommon to go to 7, 8, 9 different hospitals in the course of a week, seeing consults and admitting patients and so forth.
Which hospital did you mostly work at?
I mostly worked at St. Vincent Hospital, but also I've been involved with UMass since the beginning. When I started in practice in Worcester, there were many more hospitals now. Hahnemann Hospital was a wonderful little private hospital. Worcester City Hospital was a delightful hospital to take care of patients. There was a hospital in Holden that I occasionally went to. There was Doctors Hospital that I went to. There was Fairlawn Hospital that I went to. So there were many, many more hospitals and hospital beds. And over the years, they shrunk as hospitalizations declined for patients and lengths of stay declined.
So what were your rounds like at the hospital?
Well, I think it was obviously visiting each patient, writing a note in the chart, reviewing the x-ray tests. Most of the hospitals I worked at were teaching hospitals, so it would often be touching base with the house staff, who the interns and residents were taking care of the patient through the night. It was often touching base with the nurses, who seemed to have more information than almost anybody else about the patient's care, reviewing lab tests, developing a plan with the patient, writing a note in the chart, and then moving on.
Who are your patients generally?
They were the general mix of Worcester County patients. They almost all came from Worcester County.
Okay. And did patients have the opportunity to choose their physician?
They did in the beginning, and that's one of the major differences between, perhaps a little bit between medicines today and between the world of HMOs and managed care. I think when I started, patients came to me because they were referred by other doctors or because they'd heard of me by reputation or some other reason. So patients would come to you because they chose you or they were told that you were a good doctor by another physician. As HMOs began to be established, then you took patients more on, if you were the doctor of the day for that day, you would get assigned the patients. And it's quite a difference when a patient picks you and you're assigned to a patient. If a patient picks you, then the patient is apt to like you a great deal and so forth. On the other hand, if patients don't pick you and are just assigned to you, they think, well, he can't be very, very good because he has available appointments, he's the next number up. It's quite a difference.
How many patients of yours were in the hospital at any one time?
Well, as I mentioned, it was not uncommon to have 15 to 20 people in the hospital at a time, and it was not uncommon to see in the office another 15 people in the afternoon. So.
What do you think it was like for your family to have a physician in the household?
I think it was mixed. They had obviously some material benefits because physicians do well financially, and perhaps because of that, my wife was able to stay home with the kids. But I wasn't home as much as perhaps other fathers are. I had 2 children. My wife was great in that. Whether I came home at 7 o'clock or 9 o'clock at night, she would have supper on the table in half an hour. We always ate as a family. I had 2 kids. The 4 of us always ate 5 nights, Monday through Friday nights as a family. That was a rule, and it was almost never broken. So we did get that time together.
No matter how late you might have been.
Almost no matter how late. I mean, I guess occasionally if I came home at midnight, I might miss a meal, but it was almost unheard of. We almost always had dinner together, and sometimes I'd come home and go back to work if I had to.
Did you have any vacations?
Yeah, when I started out in a group practice with the Fallon Clinic, and their vacation policy was relatively liberal. We had 4 weeks a year, and then a week to get educational training. So we had 5 weeks away a year, and then it grew over time. So at the end, it was 6 weeks a year plus a week or 2 for, which is pretty good. That's part of the advantage of a group practice. You have someone who can cover for you, and you can.
What made you decide to become a doctor?
I guess I come from a long line of lawyers, and I went to Tufts undergraduate as well as Tufts Medical, and I went to Tufts undergraduate with the intention of potentially going to law school. The law school type of pre-law classes were not my favorite. I love science. I had a family physician who was a woman, doctor, probably somewhat unique in those times. The family and I had a great deal of respect for her. She was a delightful woman. I loved the science courses, and it just went from there.
And once you started practicing, what made you decide to keep being a doctor?
There's a tremendous amount of satisfaction, I think, in being a physician. It's a wonderful profession. Working so closely with people, sometimes people who are pretty vulnerable, and feeling that you can make a difference. And I never did not enjoy it. I always had a good time with it. So, and in addition to the fact that it has its financial rewards, as we mentioned, so there's that. But that's not what it's really all about. It's more about it's a fun day. You tend to get a lot of very positive feedback. Patients tend to like their physicians, I think, and they say nice things to you, and there's a lot of positive feedback, and And you really do feel like you made a difference at the end of the day.
Why did you choose to practice in Worcester?
I grew up in Boston. I had family in Worcester. I'm sorry, I had family in Boston. My family still lived in Boston. My mother and father. We had some property on Cape Cod. I trained in Baltimore, and I decided I wanted to come back closer to home, to be closer to my family. I had brother and sister here as well. Boston seemed awful crowded, particularly in cardiology at the time. The med school was just getting underway. It seemed like a real unique opportunity. And Worcester seemed like a very nice-sized city with reasonably attractive hospitals, sizable population. And I never really regretted that decision.
Do you have a favorite memory from when you practiced?
I don't know if there's one single favorite memory. I can remember way back to 1974 when I started many of my patients' families. And I suppose the favorite memories are making a unique diagnosis, or maybe the times where you really do make a major difference, where you feel like you've saved a life. And I think those are probably my favorite memories. And there are many. There are several of them.
How about a least favorite memory?
I guess it's when you make mistakes. I mean, all doctors make mistakes, and in my opinion, there's two kinds of mistakes. One is a mistake in judgment, where there are two choices. You can pick to operate on a patient or not to operate on a patient, and either way may be a correct way. And you decide to operate, and the patient doesn't survive the operation or whatever. And those are areas of judgment that you can't be too hard on yourself about, and you can only learn from. But then every doctor will also make some mistakes, I think, at some time during their career, because they didn't know something they should have known, or maybe a little bit of carelessness. And those are the ones that are real painful, and they don't happen often. But all doctors, I think, will make some mistakes, and you have to just kind of try to learn from them and make sure it doesn't happen again.
What were the most typical illnesses that you dealt with when you started practicing?
Well, I guess there were probably more infectious diseases than there are now. And there was a lot more, for example, uncontrolled high blood pressure. There's a lot of high blood pressure now. I think everyone knows that. Maybe a quarter of the population has high blood pressure. But back in the days when I started practicing, particularly in the days of my training, the drugs were not as powerful. They weren't as commonly used. The seriousness of high blood pressure wasn't as recognized. And so it was not uncommon to see people with extraordinarily high blood pressures, and then the effects of the high blood pressure, cerebral hemorrhages, kidney failure. There was some degree of, in cardiology, there was a degree of rheumatic fever. There was a modest amount of tuberculosis. There was some syphilis. Tuberculosis and syphilis is something I haven't seen in years. Now, rheumatic fever has become incredibly rare, much more common back then.
What was the greatest challenge for you to treat when you started practicing?
Well, I guess maybe I can answer that best by the way I think things have changed a little bit. I think that there were far fewer tests, particularly X-ray imaging. X-ray imaging is remarkable, and in the old days we had simple plain X-rays, but there weren't CAT scans and MRIs. There weren't sophisticated echocardiograms and the kind of things we rely on every day. So you were much more dependent on the history and physical. You had to spend a lot of time with the patients, working through the history and physical exam, and that became really key in taking care of patients. As testing, the history and physical is still very important, but nowadays with the kind of modern testing we have, the X-ray tests and the echocardiograms and so forth, it's just replaced a lot of the judgment based on history and physical compared to when I started.
What was one of the most important breakthroughs in disease treatment during your career?
Well, I think that the two that I would probably point to are X-ray imaging that we mentioned. When I started practice, for example, if someone was expected to have a brain mass, you did a simple chest X-ray of the head. There's a little gland in the middle of the head called the pineal gland. You hoped it was calcified, and if it was, you could see if it had moved either to the right or the left to look for a mass in the head. But many people's pineal gland wasn't calcified. It was that simple, and nowadays it almost sounds silly, but nowadays you get an MRI or a CAT scan, you get these incredible images, you know exactly what's going on. That was one thing. The second thing are the amazing explosion of drugs. I've heard that drugs, in terms of cost, will exceed the cost for hospitalization in the next year or two. So we've switched from hospitalization being the most expensive part of medicine to drugs being the most expensive part of medicine over the course of my career. And the drugs are so sophisticated and so targeted and so remarkable now, from the wide range of antibiotics to the drugs to treat heart disease. I'd look upon those two as the major breakthroughs, imaging and pharmacology.
Have you seen any breakthroughs in disease prevention throughout your career?
Yeah, I think, a lot. I think, for example, I won't say when I started medicine, smoking wasn't realized as harmful. I guess it was then. Certainly when I was in high school and college, it wasn't, though, and there were ads on the radio that, doctors smoke more Camels than any other cigarette. It was very common to see doctors smoke. I smoked not very heavily, but and I don't think I smoked by the time I got to med school, but when I was in college and high school. And I think that, so for example, and it was very common, most doctors smoked, and doctors would smoke in the hospitals. I mean, they would go and see a patient, and then they'd sit at the nurse's station and write their notes and have a cigarette. That's unheard of today. You can't smoke in a hospital today, and everyone recognizes the incredible ravages that cigarette smoking have caused the population. High cholesterol, when I was young, when I started my practice, was debated as being a risk factor for heart disease. I think we now understand how important that is for heart disease. High blood pressure was even to some degree debatable. Some people thought high blood pressure wasn't the worst thing in the world, and certainly it's not controlled to the degree it is today. So all those things in preventative care have really shifted.
What was the worst epidemic that you can recall?
I don't really know that I treated any. I mean, there was no plague or anything like that. I can't remember any. There was, as I mentioned, tuberculosis. There was a fair amount of, there was some syphilis, those kind of things. I'm not sure they were epidemics, but they were there. And
in terms of technology, what is something that doctors take for granted now that you didn't have when you started practicing or any time in your career?
Things that doctors take for granted now. I mean, I guess probably for a young doctor, it's the kind of things that we talked about. It'd be X-rays, it'd be the drug use. There are other things. Genetics, for example. Genetics was very simple when I was in med school. It was essentially Mendelian. You cross yellow corn and brown corn and get mixed corn, that kind of. But nowadays, the idea of stereotyping diseases or disease-specific genetic kind of testing is brand new and probably to some degree, I suppose, taken for granted by young physicians in training. All those things were just totally unavailable when I started practice.
What technology is still being used today that you used when you were in medical school?
Oh boy, I mean, I think the technologies are, many of the same technologies are still being used, but the differences are astounding. And I'll just give one potential example. We had respirators when I was in medical school to help people breathe, but they were the most simple things you can imagine. They were simply a piston that drove a certain amount of air into a patient, and the only thing you could set on a respirator was how much air you wanted to drive into the patient. So if you wanted to drive 150 cc's, you set the machine for 150 cc's, and it would drive that amount of air into a rock. And if the patient wasn't ready for it, it would explode their lungs, basically. So nowadays, you take a respirator, and they're incredibly sophisticated with millions of settings that you can, and parameters. Pacemakers that are now placed under the skin. When I started in medical school, were great big boxes that people wheeled around that were external, and the wires went through the skin. So pacemakers are available, but nowadays they come in little tiny packages that fit right under the skin, and people walk around with them, and they're common everyday use. It was an event back then to put in a pacemaker.
Describe one important invention that you've seen throughout the course of your career.
One important invention. Well, I think there are probably many, and I guess I'd have to, as an example, I would say maybe echocardiography, because that was something that I studied pretty extensively at Hopkins when I was doing my training in cardiology, and I think that I essentially was one of the first, if not the first, to use it in Worcester. In the beginning, it was a very simplistic technique that what we called M mode, and it would just be little squiggles of lines on a page, and then it became two-dimensional, and now they're working with three-dimensional techniques, so you can actually see pictures of a heart that look like a heart. Back then, it was just a bunch of squiggly lines. And nowadays, you can pretty much, if someone has a heart murmur, instead of spending hours and trying to figure out a physical exam, you can do an echocardiogram, and you can pretty much be certain what's the cause of the heart murmur. You can find out how someone's heart functions. That was one area of technology that I was personally involved in here in Worcester.
Did you always have access to the new medical technology?
I think so. I think Worcester is a pretty sophisticated medical community. Both the medical school and St. Vincent Hospital Worcester Medical Center were both wonderful hospitals to practice in. Both had pretty remarkable doctors, and they both had the latest in technology, which is one of the reasons I felt very comfortable about coming here. So I think I did.
Is there anything that you'd like to see invented right now in medicine?
I can't think of anything specifically. I mean, technology is moving so fast, it's unbelievable.
What were some of the most important drugs that you used in your practice?
When I finished, or in the beginning?
In the beginning, I guess.
In the beginning, the antibiotics, of course, were major, and we didn't have the wide selection that's available now, but penicillin and sulfa drugs and erythromycin were commonly available. The drugs to treat high blood pressure were relatively simple drugs. We used drugs that no one's ever heard of today, like reserpine and guanethidine and aldomet, that no one uses anymore to speak of. I can give an example of when we needed to get fluid out of people, when we needed to diurese people. We used, back when I was an intern, a simple drug called mercurhydrin. And it was a reasonably effective drug. And the common drug that's used today to diurese people is called Lasix. And that was not available when I started, but I think sometime, maybe my internship year or my first year of residency, was an experimental drug and had a number like SL43B or something like that. And I saw it used for the first time. And the patient urinated this unbelievable amount of urine after being given the drug. And I was so amazed. My comment was, that's the most amazing drug I've ever seen. That will never, ever be used in an outpatient setting. You'll have to have someone in the hospital to give this medication because it's so powerful. And now it's used all the time in an outpatient setting.
So how have the drugs used in your field changed over years of practice?
There's a lot more of them, for one thing. But one of the ways that things have changed is I think we understand a lot more how to use them, and that's based probably on some of the research studies that get done. Medicine is always kind of a balance between the art and the science of medicine. Science being when you have good experiments, like a randomized double-blind controlled trial that tells you how to use a drug, compared to just this is how it seemed to work in the last 20 patients I use it in. One is kind of the science, the other is the art. In the start of my practice, it was almost all art. It's become, there are many, many more research trials now that tell you very specifically how and when to use medications. So that's been a major shift, I think.
Did you always have access to the drugs you wanted to use?
I never had a problem. Yeah, I never was deprived. I mean, there's sometimes working with different HMOs, they will have preferred drugs, but they're pretty good about allowing you to move off the preferred list if there's a specific reason. And I never felt there was a shortage of anything.
Are there any specific breakthroughs in drugs throughout the course of your career that you'd like to mention?
No, I think we pretty much talked about the research, the amazing proliferation of drugs, and then the research that tells you how to use them.
How did changes in drugs in the drug industry affect your practice?
Well, I think it doesn't seem to me that the FDA was quite so much involved in the early years. Nowadays, you have very certain indications for a drug approved by the FDA, not approved by the FDA, black box warnings and so forth. I think that's a change. I think that there's a lot more oversight as a drug gets, seems to be a lot more oversight to me as drugs get approved. I think that's generally a good thing. Sometimes it may delay the development of drugs a bit, but it probably makes the world safer in terms of. And then there's this whole generic versus brand name drugs. I don't remember that being a big deal when I was. We never talked about generic or brand names. I think most drugs were relatively cheap. You could probably get penicillin for a couple of dollars, and nowadays you can spend hundreds of dollars for the course of antibiotics. If you use one of the clot busters, TPA it's called, is a couple of $1,000s for a single injection of it. So there was nothing like that when I was starting out. All the drugs were, 25 cents or 50 cents. It was quite different.
How did patients without money get health care?
Yeah, it seems to me when I started, they just got treated. And I don't know that there was anything magic about it. I trained, I did my internship at Baltimore City Hospital. It was a very large city hospital. And no one ever paid. I never heard about insurance or anything else. The whole internship and I don't even think residency years that I was there. And when I started practice, you just took care of people. You didn't worry so much about insurance. Nowadays, it seems to be a much bigger deal. But there also seems to be more government support programs and so forth. But I think when I started, everyone was just, hospitals would never ever turn anyone down, and you would never turn anyone down. You just expected that a certain amount of it would be care that you weren't going to be reimbursed for.
Over the years, how do you think Worcester compares to other places in terms of providing care for the underserved?
I don't have any basis for comparison. I really don't. I've only practiced in Worcester. I do think I retired a year ago. I spend a day a week working in a clinic that largely takes care of free patients, free care patients, indigent patients. I do think it's become somewhat more difficult for indigent patients to get care. There are certain things you seem to be able to get with ease, like blood tests. There's other things that are harder to get but are obtainable by x-rays. And then there are other things that are extremely difficult to get, like consults with some specialties and so forth. So I think it is harder now than it was. But I don't know how it compares to other communities. I suspect it's not a lot different.
What were some fears and concerns about socialized medicine in the 50s and 60s?
I guess they were, I never spent a lot of time thinking about it, but I think the concern was probably control. Doctors, at least used to, when I started, be fiercely independent. There was ability to choose what kind of specialty you wanted to go into. There was ability to choose where you wanted to live. Nowadays, some specialties are more crowded than others, and it would be very difficult to practice in, and there are some areas that are just overcrowded with doctors. That was not the case when I started in '74. You could just about pick your specialty, and you just about pick your area you wanted to live, and you could make a living. Nowadays, if you go into my field, cardiology, there are some areas that are so crowded it would be difficult, and I think that the fear of socialized medicine was like that. It was going to kind of control your life. People were going to tell you when to work, how much to charge, who to see, what test to order. I think that was most people's fear.
So you or any other physician that you knew weren't involved in this topic politically, were you?
I wasn't particularly involved politically in
What were your feelings on Medicare and Medicaid when they came in the 60s?
I don't know that I had much of a feeling. I will tell you one kind of interesting thing that I think would be of interest to perhaps young doctors. And that goes back to training. One huge difference between training now and then, I think, and I don't think our training was any more difficult than it is for doctors today. There's a lot of talk about how hard it was and the amount of night call that we took compared to what it's taken now. It was different. It wasn't harder or easier. It was just different. But when I started my internship, and as I mentioned, I was at a big city hospital, Baltimore City Hospital, and I was an intern, and I was the doctor. There was people who were admitted to Baltimore City Hospital were admitted to me. There was no attending. No attending ever saw the patient. I was it. I worked with a resident. We worked in teams. There was one resident, 2 interns. I was on call every night, and that sounds horrible, but it really was very different from nowadays when you're on call. You're up all night, and you get 7 or 8 admissions. We had a place to sleep, housing. I was married then, so my wife and I had a little apartment next to the hospital. I went home for supper every night. I slept through most of the night. I maybe got 1 admission every 3rd night or whatever, but I was on call 24 hours a day, 7 days a week for the patients who were admitted to me, and I was their doctor. There was nobody else. Baltimore City Hospital had a few specialists. They had a couple of cardiologists, an oncologist, a neurologist, and I could call them if I needed to get a consult. But it was the resident and I, and you took that very seriously. Nowadays, when people get admitted to a hospital, obviously they get admitted to an attending hospital, and sometimes the resident or intern may almost feel like an add-on. Very different, because we were it. There was nothing else. And then that was my internship year, and then I was interned during the Vietnam War, and every doctor had to serve in some capacity in the military. So I did my internship year, and then I did 2 years in the military. And then when I came back, Medicare was just beginning to kind of sort of kick in terms of, and so at that stage, then people were getting admitted. When they got admitted to a hospital, they weren't necessarily admitted to the intern. They had another doctor's name attached to the chart, and my feeling was, how are doctors ever going to learn if they don't, and of course nowadays everyone would think that was absolutely ridiculous to have a patient actually admitted to an intern. But that's the way it was, and we took the patients seriously, and we spent hours reading about the patients, working hard, making sure a lot of compulsiveness, not making mistakes, because you felt so responsible. Nowadays, I think when people are admitted to an attending physician, the interns and residents kind of tend to call up and say, what should I do? What do you think I should do? It wasn't that way then. There was no one to call. You could get a specialist, but you couldn't get another internist. There wasn't an internist on the staff at Baltimore City Hospital, not one. They were all specialists and then the interns and residents. Different world.
So what do you think about the programs of Medicare and Medicaid right now?
Medicare seems to, people seem to love it. It seems to be a political third rail that you don't touch. And it seems to function well for the elderly. I have less experience with Medicaid. The feeling, I think, among most doctors is that physicians are underpaid for their services with Medicaid. And that may not be quite as functional as Medicare, but I don't have strong feelings about it.
So would you agree that the government has become much more involved in healthcare since the time you started practicing to now?
Absolutely. Yeah, I mean, if you whoever makes the payment is going to look to see how they're spending their money. And if the federal government is spending a huge amount of money, for example, they're probably the #1 buyer of pacemakers these days. They're going to make sure that the pacemakers are put in appropriately. If they're the #1, if they're buying them all, they want to make sure doctors use them appropriately if they're paying for them all, or most of them, and they do.
So how do you think the government's increased involvement in healthcare has affected physicians specifically?
I don't think it's been too onerous, but it used to be, for example, the pacemaker is a good example. You used to be able to just, if you felt the patient needed a pacemaker, you put it in. Nowadays, you may have to call, or at one point, you had to call a nurse to say, this is what the patient has. I want to put a pacemaker in. The nurse would say, go ahead. I never was turned down, but it was like this extra step that like someone was looking over your shoulder. And
how about patients? How have they been affected?
I suppose that Medicare has given, I don't know, I don't know that I can answer that, but Medicare is an incredible, if you're under 65 and out of work, or you're working in a low-level job, access to medical care is huge. It's very hard to get, but you can be guaranteed if you're over 65, you're going to get health care in this country because of the Medicare program. So from that standpoint, it's kind of guaranteed access for the senior population. I think they by and large love it, and that's why it's a political thing that people don't want to touch.
What would you like to see happen with government and healthcare?
I don't know. I really don't know. I don't.
When did HMOs first start to impact your practice?
I came in 1974 to Worcester. At that point, there were no HMOs in Worcester. I joined Fallon Clinic. There was a group practice here. And Fallon established the first HMO in the area, and that was 1976. And Fallon did that in conjunction with Blue Cross and Blue Shield. It was a joint project between Fallon and Blue Cross and Blue Shield, and they started an HMO, and that was in 1976. In the beginning, it didn't impact in any way at all. There was no impact because it was a very tiny part of the patient population. But as it grew, it became more and more of Fallon's business. So it went from 1% of its business to 5% to 20% and then by the time I ended my career, it's 90% of the business of Fallon now is HMO. So it became, and it's the things we talked about in the past. Patients picked you. Now they pick an HMO and they're told to go to you. That's one aspect of it. It's so.
How much did it cost for you to go to medical school?
I can't remember the exact amount, but I've had some recent conversations with my mom and dad about this, and they believe that it's no more expensive. And I have kids that I've put through college, and then I have some nieces and nephews who are in college now, so I'm fairly familiar with how much it costs to go to college and the pain it can be for some people. But I believe, as I remember, my undergraduate tuition at Tufts was $600, and my medical school tuition was $1,500. So I think that's what it cost. But when I talked to my mom and dad about it, a new car was $500, and the house that they bought was $11,000, and it was a reasonable house. So $1,500 in those terms, they believe, and I think they're not far off, is probably the same as what it costs somebody. I mean, a new car can easily cost $35,000 now, and a tuition can be $35,000. Back then, a car was $500. I was paying $1,500 for medical school. So I'm not sure it's different. It sure has gotten expensive, and I understand a lot of people come out with immense debts. I was fortunate I didn't. Not that my parents were wealthy, but I worked, and I worked through the summers, and I moonlighted when I was in medical school, and when I went through some of my training programs.
So do you think that the costs of medical school today greatly influence the choice of young doctors after they've graduated?
I'm afraid that it may. If you have to pay off a very sizable debt, you probably don't want to go into a specialty that is a low-paying specialty. I don't have any data or facts to back that up, but that would be not good if the decision of a lifelong specialty, something you're going to do for 25 or 30 years, if the major impact of that is a financial one, if the major reason you choose it is a financial one.
How have doctors' salaries changed over the course of your career?
Again, I don't know how they would adjust for inflation. I don't want to talk about my salary when I left, but my first salary when I started at Fallon Clinic was $26,000, as I remember. I started practice at age 33. I had done, as I mentioned, I did my internship at Baltimore City, and then I was in the military for a couple of years, and then I did a residency at Baltimore City, and then a residency at Hopkins, and then a chief residency at Baltimore City, and then 2 years in cardiology. So I was 33, trained at fairly prestigious places, and was in a high-paying specialty area, and my salary was $26,000. So obviously that's hugely inflated now. I think it wouldn't be uncommon, as I understand it, to have a cardiologist starting at $150,000 now. But again, in terms of buying power, I don't know what that means. A house now is 4 times what I paid for it back then. A car is 5 times what I paid for it back then. So.
Where did most of your income come from in the early part of your career?
Well, it was all patient-driven, but it was, I would say, a lot of it, cardiologists do procedures. And unfortunately, I believe medicine is procedurally oriented so that people get paid better for doing procedures than they do for seeing patients in the office, which I don't agree with, but it's a fact. And so I would say a good chunk of it came from procedures that were done in the hospital and hospital patients, and then probably less so from outpatient visits.
How has malpractice insurance changed over the years?
I don't know how the insurance itself has changed so much, except it's gotten considerably more expensive. But I can tell you that it's in every physician's mind. I mean, it's something. I was fortunate that I went through my career without I came here in '74 and stopped a year ago, and I never had a malpractice suit against me. But it was always in the back of my mind, and I always was concerned, and I always wrote notes in the chart to try to protect myself against that. And I always ordered the tests I thought were important to order to protect against that. So it's sort of in the back, I think, of every physician's mind every day. It's a tough part of medicine. Nobody wants to be there.
What were the typical fees for an office visit when you began practicing?
Well, I don't remember what exactly. I think my guess is that a 15-minute office visit would have been $750 or something like that, and a consult might have been $30 or something in that range.
What out of out-of-pocket expenses did you have for your practice on a day-to-day basis?
Well, I joined group practice, so I was in a group practice from the beginning, and always practiced as part of a group, and therefore they took care of offices and equipment, and stationery, and secretaries and nurses, and all those kind of things. There are pros and cons to a group practice, but one of the pros is it allows you to practice medicine. You don't have to think about who the nurse you're hiring or the kind of stationery that you need to pick out. You could concentrate on seeing people.
How did you end up learning the business of medicine?
Again, Fallon always had kind of an administrator who ran the business. I don't think I was ever taught anything about the business of medicine in med school, internship, residency. So I had no training, and I just came and practiced and allowed the administrators at Fallon to run the business part of things.
Do you feel that the business aspect of medicine is something that should be covered a little bit more in the med school curriculum?
I guess the easy answer to that is yes, but having said that, I think I'm not saying private practice is dead, but it's certainly a dying, it's certainly a shrinking world. Put it that way. There's not as many people in private practice, and there's much more of a tendency to be involved in a group practice, or let someone, or be hospital based, or let someone else do the. Sometimes it's tough to be good at many things, and if you're a doctor, it's probably better to be good at seeing patients than it is at collecting bills. So let someone else do that for you.
What are some changes that you've seen in the demographics of Worcester?
I think Worcester's probably about the same size now as it was in 1974. Maybe slightly smaller, not greatly though, than in 74. And I think it has a probably higher immigrant population now. But that's a guess. I haven't seen actual numbers on it.
Yeah. How has the ethnic background of your patients changed over the years?
I'm not sure it has. Worcester has a wide ethnic background, as you know, and I think that's wonderful. I've always loved that.
How did women's health in Worcester change over the course of your practice?
I don't know that I'm really, that was a special area of mine either, that I can comment greatly on that. I mean, I think, of course, things like mammograms came into being. There were no mammograms when I was in training. They were not heard of. There was no such test. Estrogen or hormone replacement therapy is something that is up and down and all over the place. It seems to change daily, but that was something that was not talked about when I started my training and so forth. So I mean, I guess there's some differences in understanding the uniqueness of men and women in various diseases and so forth, that probably everyone got treated probably pretty much the same when I got out of training, and there's some realization that there's some uniqueness about the way people may respond to medicines or whatever it may be. So there's some of that, but
Have there been changes in how children are cared for?
Again, I'm probably not too competent to comment on that. I did, Hopkins had an amazing pediatric cardiology program, and so I did take care of a lot of kids with congenital heart disease when I came, because of my background there, but that's still a very small part of my practice, and I really didn't have a great deal to do with children. So,
how has Worcester been different from Baltimore and any other place you've practiced throughout your career?
I don't know. I don't have an answer to that. I like Worcester a lot. It's about the right size for me. Baltimore was a big city. Boston was a big city. As I say, I grew up just on the outskirts of Boston. I went to med school in Boston. And in Baltimore, if I lived 5 miles from the hospital during my later years of training, when I didn't have the bed right in the hospital compound, if I lived 5 miles away and had to go through 7 or 8 traffic lights, it was a 40-minute commute. You can live 7 miles away in Worcester and be in the hospital in 7 minutes. So Worcester's the right size for me. I love its ethnic diversity. I love its the people, the restaurants, the population. But I don't know that the practice is any difficult. I think medicine is as sophisticated in Worcester as it was in Baltimore and Boston. I was in Dallas for a little while. I practiced in Dallas, and my military time was in Dallas largely.
Would you like to share anything about your experience in Dallas practicing in the military?
No, it was the Vietnam War, and I was fortunate in that I got a job with the Public Health Service. And what I did was I treated tuberculosis for 2 years, and it was really fun. There's a great hospital in Dallas called Parkland Hospital. My office was across the street, so I was able to go to many of their teaching sessions and keep up in internal medicine and cardiology. And I had a great group of nurses and other physicians I worked with in the Public Health Service, and I treated tuberculosis for 2 years in that city. There were probably 400 or 500 new cases of tuberculosis a year then, and I saw many of them and did the contact testing and treated them.
What were public perceptions of doctors when you first started practicing?
I think they were much more positive than they are now in some ways. It's like, I guess I liken it to politicians. Nobody likes politicians, but everyone likes their politician. The person you like your representative, but you don't like politicians in general. I think when I was younger and started, doctors were very highly regarded. Nowadays, I think there's a tendency for many people not to like all doctors so much, but almost everyone likes their doctor. So I still think that there's a lot of, the people that you see will like you, by and large.
How do you feel the role of the physician in the Worcester community has changed?
I don't know. I don't have an answer. I don't know that it I don't know. I guess I'd like to say maybe many physicians are more involved in politics and trying to get things like the recent fluoridation effort done and so forth, which is unfortunately unsuccessful. But I'm not sure that's true. I don't know if they're more involved than when I was younger or not.
Were there Worcester physicians that you admired when you started practicing here?
Yeah, there were a lot. There were a number of people I really looked up to at Fallon and at the med school, and a lot of good role models. There always are. Yeah.
What was it like for the female physician in Worcester in the 50s and 60s and 70s?
I imagine it was tough, although there were female physicians at Fallon when I joined, but not many. In medical school, there were probably, in a class of 110, there were probably about 5 female physicians, female students in that class. In my internship, there were probably 40 or 45 residents in my internship class. There were 2 women that I remember. And nowadays, it's much more 50-50 in medical schools and in internships. So there clearly weren't as many. And I imagine it was difficult. I think it's very difficult to balance a role as a mother, for example, and as a physician. I don't have real first-hand knowledge.
How did group practices or hospitals treat minority physicians when you practiced? I don't know that I can answer that either. There were certain hospitals in Worcester where certain religious groups, for example, would affiliate with, and you would have difficulty getting on the staff of X hospital if you were Y religion. But that doesn't address the real minority issue. I don't really know that I have an answer. I never saw or never had any physicians really complain to me that they had an issue, but they may not have. I mean, they may not have.
best about practicing in Worcester?
I mean, as I mentioned before, I like Worcester a lot. I like the size of Worcester. It's just about right. There aren't a lot of big traffic jams like there were in Boston and Baltimore. There's ethnic diversity. I think there's great restaurants and art museums, and it's a good community. It's been fun for me. I wouldn't have done it differently. I would come back here in a minute.
Is there anything you don't like about practicing in this area?
I wish Worcester would have a little bit better sense of itself, or a little more positive image of itself. It's a great place, but people get down on it for whatever reason, and I think that's a mistake.
Okay, well, that almost brings us to the end of our interview. Before we wrap up, is there another experience or story that you'd like to share from med school or from any time in your career?
No, I don't think so. Just to say that it's been, I've thoroughly enjoyed my years of practice. It's a wonderful profession. I would recommend it to anybody. I don't think anyone would be disappointed in it. It is hard work. You need to be dedicated to it. It becomes a way of life, almost more than a job. And it's a great field.
Do you have any comments on how your field of cardiology has changed over the years?
It's become much more procedure-oriented. For example, bypass and angioplasty. There were so many things that were not even available or heard of when I started practicing, from electrophysiology to angioplasty to implantable defibrillators. It's become much more procedure-based, much more technologic, perhaps, than hands-on.
Okay. And lastly, do you have any further advice for young doctors who are starting out?
I think just to remember that it is really about patient care. Being a good doctor doesn't necessarily mean you have to be brilliant. It is more about hard work. It's about humility. It's about being compulsive, and just to enjoy it. It's a great field.
Okay, well, thank you very much, Dr. Bishop.
Thank you.